Sir, we are in line live, sir, now.
Okay. So, welcome, my dear friends, colleagues from all over the world for the Pure Urology Facebook program. So, today I will be conducting the session. I'm Dr. Siddhalinga Swami. So, today we have a very interesting, very old topic, but still it has been dealt in depth in all the conferences, and still we have the doubts. So, that is the PCNL puncture part. So as you know, many different techniques have come up, many methods have been described, and many people get confused which one to use, which one to apply. So today we have an eminent speaker who can analyze these things for us and make it into a simplest way where it will be useful for our day-to-day practice. So today we have Dr. Maneesh Sinha, sir. Sir, welcome to the show, sir.
Thank you. Thank you.
Sir, a brief discussion about your careers. So whom do you call as your urology mentor?
I have three gods in urology: Dr. Ganesh Gopalakrishna, Dr. Nitin Kekre, and Dr. Naiman Chakra. So we used to call them the creator, the destroyer, and the preserver. You take your guess as to who was who. And other than the three gods, I have a boss I work for who's taught me a lot, Dr. Venkatesh Krishnamurthy. So these four people.
Excellent, sir, excellent. So what made you to choose urology, sir?
When I was in Safdarjung in Delhi, there were 4 OTs. And in our OTs, we would do all the amputations and thyroidectomies and gallbladders. And usually everything was open that day. Yeah. And in the urology OT, the professor there would just look inside, do something, and the patient would be out. So I was very fascinated by endourology. So that's what made me take this up.
Nice, sir, nice. So you had all the teaching and schooling in the North India, and you settled in Bangalore. So any specific reasons or anything?
So when I wanted a job, I called up Dr. Ganesh and Dr. Nitin. They were both in Coimbatore and Vellore. And
yes, sir.
Knowing me, they knew NU Hospital, and they were very emphatic that I should come and join NU Hospital. And I think that was the only interview I needed. They called up Dr. Venkatesh, and I had the job. So that's how I'm here.
Nice, sir, nice, sir. So I will just go with your brief introduction about your CV, sir. Then we will go ahead with the talk.
Yeah, sure.
So once again, welcome everyone for this Pure Urology Facebook program, which we conduct on alternate day at 5 o'clock Indian Standard Time. So today we have a video-based presentation on PCNL CM interpretation by Dr. Maneesh Sinha. So Dr. Maneesh Sinha is currently the consultant urologist and head of the department at NU Hospitals, Bangalore. After having completed his MBBS at prestigious Maulana Azad Medical College in New Delhi, he trained in general surgery at Safdarjung. His zeal in training urology took him to the Christian Medical College, Vellore, where he acquired in MCH and DNB degrees. He worked 5 years at Tata Main Hospital in Jamshedpur, where he was instrumental in setting up a department of urology. He joined NU Hospitals in 2010 and developed a keen interest in stone and laser endourology, vascular access for dialysis, and renal transplant. His permanent for innovation and training has driven him to develop the effective models for laparoscopy endourology training for urology residents. And just we were discussing with sir where he mentioned about the training models he has set up. He is using a vegetable model for PCNL and a vegetable potato model for the TRP training, which has been going on very well. So any interested candidates can contact him. He is very good at that. So recognition from urological community has come in awards for many national and international publications, and for the work he has been quoted. And nothing but the less, other than urology, he's a very good. He is very good in poetry, both in English and Hindi. So let us listen to Dr. Maneesh Sinha sir about this PCNL puncture and his interpretations, how he goes about. Over to you, sir.
Thank you very much for that introduction. I will straight away go into the presentation. Give me a minute to share my screen.
Yes, sir.
Okay. If you can see the screen, I
Yes, sir.
will start.
Yeah. Yes, sir. Please go ahead.
Okay. So what I tell all my residents is that remember that you have no depth perception, no tactile stimulus, and even unlike laparoscopy where you assess depth by touching, you only have a two-dimensional fluoroscopy screen. So try judging any distance with both eyes open, then close one eye and try and judge the distance between two objects. So it's monoplanar vision, which is a problem. So how do we get over this? It is simple mathematics. It needs some patience, but we will be able to do it. Please interrupt me if there is anything that I rush through and you cannot understand.
Sure, sir. Sure. Yeah.
So the gray circle on top is the patient. The rest is all self-explanatory. The red is the needle. The calyx is there. We don't see the needle once it's punctured the skin. We obviously don't see the calyx at all. What we are seeing is the fluoroscopy screen only at the bottom. So that is going to guide us throughout this presentation. You have to pay attention there. The other point that you need to remember is that this image will change depending on where your eye, or rather that triangular cone C-arm is. So depending on where you are looking from, this shadow will change. So these are the two things that you need to understand.
Yeah.
Now, I use the triangulation technique, and I will start with that. Not because it is difficult, but because it is perceived to be difficult. I find it easier. So let us see what happens there. Now, suppose I keep my C-arm only at 0 degrees and I start moving the needle. I stop at the edge of the calyx. Now, what happens is on the floor, I see the fluoroscopy screen at 0, it has reached. So we are all right now. So should I push? Should I not push? At this point, no, you are not sure where you are. Why? Because suppose I have a needle which is going superficial to the calyx, this is what will happen. The fluoroscopy image is exactly the same. The tip of the needle is touching the edge of the calyx. You can keep pushing, you will either go into the wrong area in the calyx in an infundibulum, or you will never reach it. The same image, exact same image, if we are deep to the kidney.
Yes, sir.
So now how do I decide whether I am at the correct depth or at the wrong depth? So now we have the C-arm at 0 degrees. And we have this picture where the needle tip is touching the edge of the calyx. Or in our hospital, we turn the C-arm towards the surgeon. So here, I will turn the C-arm towards the surgeon.
So that you mean the top part of the C-arm will be rotating towards the surgeon.
Towards the surgeon.
Right, sir.
So what happens now is that the relationship between the tip of the needle and the edge of the calyx does not change. You don't have to look at anything else. Just look at the tip of the needle and the edge of the calyx.
Right, sir.
That is your target is the edge of the calyx. Not the infundibulum, not the pelvis, the edge of the calyx. So here it will continue to point at 30 at the edge of the calyx.
Yes.
The other thing I want to specify is that this 30 degree is very arbitrary. In fact, very hardly will I turn the C-arm to 30 degrees because there's too much of movement.
Oh, yes, sir.
You turn it to 10 degrees is what I have found to be adequate if I'm doing this technique.
Okay. Sir.
Don't go too much by that 30 degrees. Now, this is what you will see in an actual patient. The upper image is at 0 degree. It's pointing at the edge of the calyx. The lower image is with the C-arm at 30 degrees. Again, it is pointing at the edge of the calyx. It is not the same image. If you see the gas shadows, they've changed. So it is at 0 and 30. And once I have got this at 30, I will come back to 0. And then it's a simple matter of pushing in by a half a centimeter or so and getting into the calyx.
Right.
Now, what happens if the needle is superficial?
Yeah.
Again, 0, we have gone through this. It touches the edge of the calyx. When you turn, now a part of the needle, the shadow of the needle is falling on top of the calyx. the gray shadow you can make out here, is falling on the calyx. So what it appears is that at 0, it has reached the edge, but at 30, you have crossed the edge of the calyx. So this means that the needle is superficial, and now you need to direct it a little deeper.
Right.
The same patient at 0, and at one point, it has crossed the edge of the needle, the calyx. So this needle is superficial.
Right, sir.
Now, what happens when we go deep? When we go deep, 0 is the same. But when we turn to 30, now instead of a shadow falling on another, what happens is that between the green calyx and the tip of the red needle, some X-ray beams are escaping. So that appears as though the needle has not yet reached the calyx.
Okay, sir. Right.
It is, if you follow this mathematics, superficial, deep, correct level is very easy to understand.
Right, sir. Right,
During
sir.
implementation, there is a problem, especially if you don't have a distended calyx. Your margin of error, we have measured it on a CT scan, is 2 to 6 millimeters. So that is a challenge. All the residents tend to move their hand too much outside. But remember, at the tip, your movement needed is some 2 to 6 millimeters. So don't move your hand too much.
Sir, right.
This is the same thing presented in the same patient in the X-ray. So at 0, the needle has reached the edge of the calyx, and at 30, it has not reached. So I am too vertical. The needle is too deep. I need to make it a little horizontal or superficial, and then I will be able to reach the calyx.
Right, sir. I think everything is on prone position of the patient.
As of now, prone. Yes, standard prone position. And very good, you brought up that point. I will come to it. Now, the end-on puncture technique, I will not be showing you images because I don't do the end-on puncture. Okay. But in principle, it is very easy to understand. We need to turn the C-arm at craniocaudal and mediolateral.
Okay.
Suppose your needle is pointing like this, the C-arm has to be right at the back. It cannot be looking here. Suppose it is like this, you can keep it, but both craniocaudal and mediolateral. Once you have done that adjustment, which I find very difficult, but some surgeons find it very easy. So after that, this black dot that you see at the edge of the calyx, this must keep appearing like the same black dot. You should not be seeing the needle. So this is where I find it difficult, because you have to do an end-on puncture. Either you stay at that angle and keep on going, your hand gets radiated, and you cannot see how deep your needle is going. Or you come back to 0, you see how deep it is going, but you're not sure if you're in the right direction. So which is why I personally don't like 0, but having said that, it is the most popular technique. So this is the end-on technique. In the end-on technique, what sometimes happens is, okay, I think I can see the dot approximately, let me go in. That approximately doesn't work. You have to be very, very exact. You have to be pointing at the edge of the calyx. If you can see the body of the needle on the fluoroscopy screen below, you can see a needle.
Yes, sir.
It's not a good end-on technique, because you will end up puncturing somewhere in the infundibulum or in the pelvis, not where you want to go. Similarly, if you can see the needle in the opposite direction, you will end up puncturing too deep. So again, too superficial, too deep, it is difficult to make out. So in 0 degree, it is important to make that bullseye. You have to have the bullseye at all times. Now, so when I made this first presentation, Dr. Santosh from Vellore asked, how is supine PCNL puncture different?
Super. Yes.
And believe me, it is no different. And I am just going to repeat myself in the second half, except that with inputs from my seniors, the diagrams have gotten a little better. Okay. So this is a typical prone patient. The black is the vertebra. I hope it looks like a vertebra.
Yes, sir. Yes,
and we are going to concentrate on the right kidney, which is the dark green kidney.
Okay, sir. Yeah.
Okay. So now, first, let me turn the patient supine.
Okay.
So when we turn the patient supine, it is not a complete supine position. At least what we use is the classical modified Valdivia Galdakao position. And what I want to emphasize here is that the calyces are now pointing laterally. So unlike a prone PCNL, in a supine PCNL, the anterior posterior has less importance. I won't say no importance, but what you are going to aim for is the lateral calyx.
True, sir.
And since that is very easy to make out on a fluoroscopy screen, I find supine PCNL easier to do than prone. Now, obviously, the kidney has come to the opposite side, so the surgeon is also going to come to the opposite side. So this is going to be the surgeon side. Now, for simplicity, let me remove the vertebra and let me remove the opposite kidney. And now you will see that we are doing the exact same thing that we do in a prone PCNL. In a prone PCNL, the best angle for the needle is horizontal.
Yeah.
You have to have your needle horizontal to the floor. If you keep it pointing upwards, you will not be able to move too much. If you keep a little down, no problem, but I prefer it horizontal, which is what is recommended also. So now let's see, patient is supine. How does it differ? The needle reaches in 0 degrees.
Yeah.
The shadow also reaches the edge of the calyx.
Right.
I am turning the C-arm 30 degrees towards the surgeon. No change. The
Yes.
needle tip and the edge of the calyx maintain their relationship. Now, what happens if I'm superficial? Again, at 0, the needle has reached. I turn at 30, and again, I have the needle crossing the edge of the calyx. So this needle is superficial. Now, allow me to introduce one more concept. A very difficult thing for residents to diagnose is how superficial or how deep am I? So that is also, I hope you will be able to appreciate that the needle moves and the shadow crosses over even further. Yeah. I'm going to run this one more time just to make it clear. So the needle becomes more superficial, the shadow crosses even further. Yes. Now, as the needle comes closer to the kidney, the shadow comes closer to the edge. It doesn't touch the edge, it is still crossing. But that is how you can assess how deep and how superficial. Needs a bit of practice, needs definitely you need some mentoring to understand all this, but I hope the concept is clear. Now, let me go deep. So I think by now you would know that when I turn at 30, the needle will move away from the edge of the calyx. So which is what is happening here. The needle appears to be moving away if you are doing continuous fluoroscopy. You don't need continuous. You can just do 0, 10, 20, 30, whatever you want. When you turn it towards the surgeon, you'll get this image. Again, now, instead of the needle being on top, the calyx is on top and X-ray beams are escaping between the calyx and the needle tip. True. Assessment of how deep we are. As we go too deep, the needle moves even further away at 30 degrees. As we come closer to the kidney, you will see the needle moving close. Although it will move close, there will be a 1 or 2 millimeter gap at 30 degrees. I must emphasize that that 1 or 2 millimeter gap is important in undilated systems. Don't ignore it. You must be pointing right at the edge of the calyx. So I hope it's become clear that depth assessment on fluoroscopy, it does not matter whether you're doing a prone or a supine PCNL puncture. True. Next question was, can you do an end-on puncture in supine PCNL? Theoretically, very possible. There is no problem at all, except that I suppose sometimes the vertebra will come in the way and you will need your C-arm at completely horizontal at 90 degrees. And that might not be very ergonomic.
Yeah.
So in supine PCNL, anyway, you have the needle horizontal, so you don't have to worry too much about one angle, and it becomes easy to use the triangulation.
Sure, sir.
So that was my short presentation. I hope it was worthwhile for whoever is attending. Thank you.
It was an excellent presentation, sir. So main idea what we got from this is definitely we have to fix our movement of the C-arm to only one side, and that will not make the things difficult. So if you remember too many positions of the C-arm, so everything will be jumbled up, and clinically we can't apply that. What do you say, sir?
Yes. So in an much earlier presentation, what I had drawn on the C-arm screen was a one-eyed monkey doing this. So imagine yourself with one eye closed, sitting on that C-arm head. And whatever you're seeing is the shadow. You're not seeing the needle or the calyx. Then it becomes very easy.
So it was excellent, sir. So this will give us a perception, but we have to make sure that the tip of the needle is at the calyx. Then we can assess by moving the C-arm. So what we normally do or commonly do is we enter into a calyx once we remove the needle, once the water does not come, then we cross-check. What do you say about this, sir?
Yeah, so if you have entered and you have entered in the wrong place, then game over. You will be dilating. You just see urine. So if you do this 030, 030, so we used to go to Puttaparthi.
Okay. Sir.
And they saw me doing my 030, 030. And initially the boys actually laughed. And but over a period of time, we used to go, of course, very often. Anytime they would not get a puncture, they would come and then they did that 030, 030. After that, they were actually practicing on the bottle gourd model.
Okay.
So, and after I left, some batches taught the next batches also on the bottle gourd model. So be patient. Don't be in a hurry you don't have to prove a point by getting urine out immediately. Take your time, puncture correctly. And that is simple mathematics.
True, sir. True. So what is your advice for the initial people, initial young urologist who wants to go to start the Pcnl? So as you have said, the initial puncture is the most important thing, as you have very excellently shown to us. So few minor points when the C-arm and everything will suggest that it is in the calyx, but still the urine will not come or the guide wire will not go. So what will be your suggestions for that time, sir?
Okay. So my first suggestion, if you are going out of your institute and doing your first Pcnl outside, I'm quoting Dr. Ganesh, when I was leaving, he said, look for a PUJ obstruction with a small pelvic calculus with gross hydronephrosis.
Yes.
So patient selection is the most important. Do not attempt, your first patient should not be a small mini perk for a small stone or a staghorn. So those are dangerous situations. So look for a dilated system. Second is, like you said, make one adjustment to your C-arm. Some people do it craniocaudal, some people do it opposite to the surgeon. Whatever, but understand that what you're seeing is the shadow of the calyx and the shadow of the needle.
Right, sir. Right, sir.
Third is, don't aim for anywhere in the pieces. It has to be the edge of the calyx. We've been trying to publish another finding. We call it splitting the papilla. So if you have gone right through the C of the calyx, you can see the papilla very clearly. But it's been rejected, not because I think it's not scientific, but because nobody else looks for it. And if you've made your puncture correctly, you can actually come out into the parenchyma and look for it. I'm not advising anybody to do that, but it is a finding. Actually, when Pradeep and your friend Pramod were there, if you do not split the papilla, it's biryani for everybody in the OT.
Right. He used to tell me that. So my question was on that. The same question was there. So is it any difference if we puncture the exact in the papilla or in the fornices? So because it hardly takes 1 or 2 mm of difference, you get the water, guide wire will go. But any difference in that, sir?
No. So the outcomes, as far as they are concerned, we looked at our own numbers where we actually split the papilla, and in patients where we did not split the papilla. In patients where we did not split, we were not going in the infundibulum. We were just not We were in the fornix, like you
It's the
said.
fornicel,
Yeah.
some
So,
angle.
very small numbers, but what we found that the blood loss was less if you split the papilla. But I would not split hairs over splitting the papilla. I would say aim for the fornix anywhere. Why we say split the papilla is because if you keep trying to do that, you will not ever go into the infundibulum. And that is what is dangerous.
Probably the papillary region is the most shortest distance, and the thinnest parenchyma will be over the papilla, not at the fornices. Definitely.
Yes.
Right. And now we have around more than 150 people watching live, sir.
Okay.
So depending upon what type of puncture, that is bullseye or the triangulation method, as you have already said, the bullseye you are not practicing, but many people are doing the bullseye technique.
Yes.
I have also tried this bullseye with the 30-degree angle, but believe me, it's not practically possible, and it's a headache there.
Yeah, no, that's a very important point you've raised. We were all taught 30 degrees, and there is this great fixation with 30 degrees. And in a bullseye, why will the calyx decide it wants to point only at 30 degrees? It can point anywhere.
Yes,
so
yes.
You have to turn both craniocaudal and 10, 20, 30 and this way. So wherever you get that zero, you can fix it. And I know Santosh does it in 1 second. Once he gets that, he just pushes the needle in that direction. Okay. So it depends on what you are comfortable with.
Excellent, sir. Excellent. So thanks a lot, sir. We have few appreciations for you on the chat box. Dr. Manas Babu has specially thanked you after watching your workshop. He did his first Pcnl. He's more happy to share that. So nice, sir. Nice, excellent talk. A brief and crisp technique. I think this video will be helpful for many urologists, whoever wants to start or whoever wants to adapt to this change of angle of 30 degree. So it will be very useful for them, sir. And I was very keen in asking for the supine Pcnl, and you have made that video. I was excellent, sir. That was a super one, and that animations are also excellent, sir. Thanks a lot for this thing, sir.
Thank you. For anybody who is interested, other than on Pure Urology, I suppose this will be available.
Yes.
I'm also making one video which is already posted on the NU Hospital's YouTube page, and the other one also on the supine Pcnl. I will be putting it up there.
Right, sir. Right.
If anybody has questions, please ask me there. Yes. I'll be happy.
Please post it into the Face Urology, Pure Urology Facebook page, sir.
Okay,
so
I'll
it will be more widely accessible for everybody.
Sure. I'll do that.
Thanks a lot, sir. Thanks a lot.
Thank you so much.
Thank you.
Thank you. Bye-bye. Thank you.
Bye, sir.
Thank you to Dr. Chandramohan also. Please say thanks to him.
Yes, sir. Please. I will convey him, sir. Thank you. Thanks a lot.
Bye.